Good morning, sir and ma'am. My name is Dr. Harini Jaraman. Today I'm going to be presenting the data pertaining to acromegaly at our center. So as we know, acromegaly is a state of GH and IGF-1 excess, which is characterized by excessive somatic growth, progressive soft tissue swelling and acral enlargement. It is associated with comorbidities such as diabetes mellitus, hypertension, cardiomyopathy and OSA, which can lead to morbidity that can lead to premature mortality. Transphenoidal surgery remains to be the primary treatment modality to achieve disease control. Radiotherapy and medical management could be used in addition to surgery when it's unavailable, contraindicated or declined. So we aim to analyze the characteristics of the patients pertaining to acromegaly, that was pertaining to the patient demographics, the clinical spectrum, hormonal profiles, radiological findings, the treatment modalities and survival outcome. Our objective was to also understand if these patient characteristics could have a correlation with the survival outcome. We assess the remission amongst the different modalities of treatment. So this was a hospital-based observational study, ambispective, conducted over a decade, and we had included all the patient data and tried to understand whether these patient variables could correlate with remission. So we used the Pearson's correlation coefficient test for the correlation. SPSS 24 was used for data analysis, and the results are expressed in mean, standard deviation, percentage and proportion. So moving ahead to the results, we had a total of about 20 patients. There were 13 women and 7 males. The mean age of presentation in our study was about 45 years, and it ranged from about 13 years to 72 years. Our patients hailed from Haveri to Kasaragod. So the predominant clinical presenting findings noted in our study was headache, acral enlargement, coarsening of the facial features. There was deepening of the voice, cutaneous manifestations such as excessive sweating. There was also visual field disturbances. We had one patient of acrogigantism, one patient of nasal polyp presenting with epistasis, 2 cases of carpal tunnel syndrome, 2 patients with pituitary apoplexy. The lag period of symptoms, the mean duration is about 9.25 years, ranging from 2 to 25 years. 60% of our patients were diabetics with a mean HbA1c of about 8.4, 50% were hypertensive. We had 5 cases with concentric LVH, 3 cases each with pre-diabetes and dyslipidemia. 2 out of 20 patients had grade 1 fatty liver, and 1 patient was a case of severe OSA on CPAP. The mean FIB-4 index was about 0.7, and proceeding ahead, these are the clinical images of our patients where we can see there is characteristic acromegaloid facies that was noted amongst our patients. The spectrum of hormone axis, central hypothyroidism was the most common spectrum involved, followed by hypogonadism in 75%, hypercortisolemia in 45%, hyperprolactinemia in 25%. IGF-1 levels were elevated. Post glucose growth hormone suppressibility was not noted, and it ranged from 61.16 to 146. MRI pituitary was done in all our patients. It was suggestive of pituitary macroadenoma in all cases, with mass effect and optic chiasma noted in 25 and 55% respectively. We had also done the MRI pituitary protocol NOS grading, and we found that there were 2 cases in grade 0, 3 cases in grade 1, 1 case in grade 2, 6 cases belonging to grade 3, and 8 cases belonging to grade 4. These are the MRI pituitary imagings that are seen of our patients. A very interesting case in case 1, which is that of an acrogigantism boy with a very highly vascular tumor extending to the base of the 3rd ventricle. Case 4 highlights a pituitary apoplexy where we can see GRE blooming. I'll come ahead with this. So pertaining to the treatment advice, I'd like to say that TSS was advised in all 20 patients. It was done in about 16 cases. Preoperative octreotide was used in 1 patient. TSS was not done in 4 patients. 1 of them is awaiting surgery at present. He is on preoperative octreotide. 1 is unwilling for treatment. 2 couldn't obtain fitness because of surgery because of their comorbidities, and hence they've been advised radiation. 1 of whom is already in remission. So in the TSS done group, we have the only surgery is about 8 patients. TSS with octreotide is about 6 patients. TSS octreotide and radiation was used in 2 patients. So in the TSS only group, 5 patients are in remission, 3 patients are still having residual disease. TSS and octreotide group, 3 each with remission and residual disease. The TSS octreotide and radiation group, which contain 2 patients, both of them are in remission. So CSF leak was observed in about 3 cases, transient DI in 5 cases. Histopathology confirmed pituitary adenoma in all 6 cases with low MIB index. Remission was observed in 65% of the individuals, residual in 35% cases. 13 patients are receiving hormone replacement treatment, and 19 patients are alive and periodically following up. 1 patient had passed away because of COVID ARDS. However, he was in remission pertaining to the acromegaly point of view. So 8 out of 10 patients noted that there was a decrease in their antihypertensive requirement, and 6 out of 12 patients noted that there was a decrease in their anti-diabetic medication requirement. Coming to the histopathology findings, so we can see that there's a sheet-like pattern of the pituitary adenoma with a loss of reticulin network. I'd like to just specify about 2 extra cases. One, as we can see, is a case of the pituitary apoplexy. So here she presented with GRE blooming that could be seen on the MRI, and the corresponding histopathology is suggestive of a sheet-like pattern with interstitial hemorrhage interspersed. Then we have the acrogigantism boy with a very highly vascular tumor which is extending to the base of the third ventricle. As we can see, the sheet of the cells are arranged around the perivascular space. So these were the 2 cases I highlighted to just draw to inference that there was wonderful clinical, radiological and pathological correlation that we could get. Coming ahead, these are the individual bar charts that are comparing our individual IGF-1 levels. So we tried to compare it in the surgery only group and the surgery with the SSA group. We also conducted to see if there was any statistical difference. There was no statistical difference in both the groups. However, we could note that the median drop in the IGF-1 levels was far more significant in the surgery with SSA group than the surgery group, and there was lesser amount of variability. We also went ahead and conducted a correlation analysis. So we could find out that increased age, higher BMI, higher HbA1c, the longer duration of DM, hypertension, a lower AF and 2D echo, higher score in his scores, stop bank scores, and the size lesion in the MRI with NOS grading had correlated with poorer remission. These are certain other studies that have been done in India pertaining to the acromegaly case series. So in conclusion, I'd like to say that appropriate management of growth hormone secreting pituitary adenoma and optimizing the metabolic parameters are very imperative in reducing the disease morbidity and mortality and to improve the quality of life of patients with acromegaly. The use of somatostatin analogs along with TSS may improve the remission rates and they can reduce the cardiometabolic burden of acromegaly. These results highlight that there is a need for collaborative efforts of the pituitary care team, including endocrinologists, radiologists, neurologists and pathologists, suggesting potential areas for refinement in surgical procedures to remove larger tumors, leading to further improvement in remission rates. Thank you so much.
Interesting data on acromegaly. How many microadenoma cases you encountered in? All were macroadenomas?
So all were pituitary macroadenomas. The mean dimension that was noted of the MRI size in the pituitary was about 2.3 to 2.6 into 2 centimeters or so. And we had a significant number of patients who were belonging to the NOS grade 3 and NOS grade 4, 6 and 8 respectively.
Okay. What you meant by ambispective pattern study?
So what we had done is we had followed up the patients both retrospectively as well as prospectively. So I joined my DM course in about 2023 February. So we had a number of cases where we followed it up prospectively for whom we had taken the clinical assessment in first time. We had also had patients who were following up as cases of acromegaly which had been operated previously. So the data, we had followed it ambispectively. That's what I did.
Yeah, it's regarding the this sleep apnea, all those things which you had shown. Was there a uniformity in terms of assessing all these patients, or at certain points of time the diagnostic criteria has changed, like sleep apnea, you have put in a stop bank questionnaire you have shown,
yes,
and then you had also shown that some patients were on CPAP.
Yes, sir.
So those means,
sure.
Did everyone have a similar form of assessment? Because
yes,
you're trying to look at a correlation at the end between these features, that is
yes,
why I asked.
So I'd like to mention that there was one patient who had been diagnosed with a case of severe OSA, and that was on a confirmed testing that had been done with the sleep apnea testing. For all the other patients, though we had advised, they had not gone ahead with it. So I used the stop bank questionnaire tool, sir, to understand who would be at a risk. So the mean score that we could find in our study was about 3. It ranged from 1 to 5, and with predominantly the patients belonging to the intermediate risk group, sir.
So some of them had a full sleep study, some of them did not have.
So there was just one patient who underwent the full sleep study and was detected with severe sleep apnea. He was on a home-based CPAP device.
Okay. And I also saw that you put FSH as a criteria for non-addism as a criteria, FSH and mean FSH. Why do you put FSH as a criteria?
That was predominantly in pertaining to, we had a number of patients who were postmenopausal females in whom they had used FSH as a tool to understand that it was suggestive of hypogonadism because of the
so it is an S or no? For men, I think it won't be a...
For men, sir, we had 5 out of 7 patients who had very low testosterone levels at about 300 micrograms, and they presented with symptoms of hypogonadism, sir. We had a total of about 8 women who had presented with secondary amenorrhea, and 4 patients who had approached us predominantly with infertility as their complaint.
So that actually is only a representative thing which you showed. It's got both men and women in that, because I just saw that you put a criteria FSH and a range for that. Yeah. And this octreotide you have been giving pre-op or post-op, or it's continuing? What is the sort of?
So we have used, in terms of pre-treatment octreotide, we have at present used it in only 3 patients. One was the patient in whom there was advice for radiation. So there was one patient who has had a diminished lung capacity because of a previous history of TB, and he couldn't get the clearance from the anesthesia side to undergo the TSS because of severely diminished lung volumes in the PFT. So for him, we've been using octreotide, and he's also scheduled for radiation. So he's going to be receiving the VMAT form of IMRT, about 5,400 GY and 180 GY in 30 fractions. So that was one case. The other patient is a male who's been waiting for surgery. So for the TSS procedure, now he is currently in his 4th month of the octreotide therapy, sir. And there was an acrogigantism boy in whom they used acromegaly just prior to the surgery as well. So it was good.
So finally, the remission rates which you have mentioned at the end, as you have tried to correlate the use of octreotide with remission rates. Sir, okay. So that is a mixed basket of pre-op, post-op, everything together?
Yes, sir. That's a mixed basket. The remission and the residual rates that I had mentioned is a mixed basket that included the surgery group also, the surgery with SSA group also, and the radiation group.
When you say SSA group, that includes patients who are received with pre-op, patients who continue to receive it, everything in the same basket.
With octreotide, yes.
Okay.
Yes, sir. And we found that, of course, though larger studies are, because the sample size is very small, larger studies are required to really understand if there was any statistical significance. But when I tried to find out, all I could see that the median drop in the IGF was far more when I used an octreotide with a somatostatin analog with the surgery rather than the only surgery groups.
Pre-op.
TSS with octreotide in the post-operative period.
The post-op, yes. Okay.
How many of these patients had received RT, and what form of RT was offered? Was it a stereotactic or conventional?
Yes, ma'am. So the one patient is at presently receiving the VMAT form of IMRT, about 5,400 GY units, totally scheduled for 30 fractions, where he'll be receiving 180 GY. He's presently undergoing at our center the 10th fraction of radiotherapy just yesterday. That is one patient. The second patient who had achieved radiation had received it at another center, so we don't have the details, and that is the patient who had passed away because of COVID ARDS. Although just prior to the COVID ARDS, when he had followed up, the IGF-1 levels were normalized to the standardized age parameters. There is one patient who's been advised for radiation, is yet to undergo.
And was immunohistochemistry offered for all these patients? Were they co-secreting with prolactin? Have you looked at that?
So immunohistochemistry was offered, but the patients were not. It was not done at our center commonly, and the patients were non-affording to do it at an outside center or with a tie-up center. So we could find out just the histopathology confirmation, which was suggestive of a pituitary adenoma and low head index.
One question: what was your cutoff for the remission and cure of acromegaly in your patients included in this series?
Pertaining to the remission or the cure, sir, we assessed on the basis of the improvement in the clinical symptoms and signs, where we assessed in terms of acute symptoms, because headache was one of the most common symptoms, visual field defects was noted, whether there's a resolution in that. Then in terms of progressive soft tissue swelling, if there was a regression, we had also done IGF-1 levels at about 12 weeks, and we followed it up one at six months also into it to see whether it had normalized for their particular age. Some patients we had also done the post-glucose growth hormone suppressibility, and I used the cutoff that in some patients we could get the cutoff of, because of the sensitivity of the assays, we had used the 1 microgram per day. Certain patients just recently, who were willing, we had used the cutoff of less than 0.4 for the higher sensitivity.
Which test will be ideal? What you think? GH?
So I think IGF-1 is one of the best tests, because IGF-1 is a more integrated marker of the GH secretion. It has a more stable half-life, 12 to 15. It's non-pulsatile in nature. And so the IGF level that would be standardized for their age and gender, that would be the marker for remission.
Okay.
Thank you, sir. Thank you, ma'am.